and warm welcome to everyone. Good afternoon. Welcome for the post-lunch session on Insulin Symposium. As sir said, we have all the stalwart speakers with us today. To start the talk, we have Dr. Gangopadhyay with us. Sir is an MD, FRCP and CCST, renowned endocrinologist and practicing extensively in India and abroad. After doing MD in medicine, he went on to complete his MRCP from London. And he has won many awards in UK for papers and presentations, including Owen Wade Prize, Stephen Whitaker Prize, Nasi Prize, Society of Endocrinology Prize. And he's been an investigator in multiple international trials, published many papers, and Scientific Secretary of Diabetes India and IdeaCon. Welcome, sir.
And this year IdeaCon in Kolkata, he is hosting. He is one of the fabulous 14, or fortunate 14, and Kalyanda is heading the team this year. They rotate and most important I must speak about him, Alka, is that I'm not telling it, my lunch I already had, no motive. He's a fabulous speaker, and I have heard him on insulin in Guwahati. I have heard him speaking on insulin in various other forums. He's very clear, crystal clear, and his messages are very loud. So with this, over to KK. I call him Kalyanda. Over to Kalyanda to make his presentation. He's going to speak to us on a very important topic. I'll just introduce me and Alka in topic this way, that inpatient diabetes management is of very, very important. We know critical care management, where we have the numbers, what we should manage. But many of the patients in non-critically, they are also non-critical, but they are otherwise critical care. Am I getting my point? They are not in the ICU, Dr. Sahab, but they are in the inpatient. They have to be managed well. And if you go to any ward today, on your right one diabetic, on the left one diabetic, and general medicine ward, anybody, it's very, very common. So he is going to touch this one. He is going to speak to us about this non-critical yet critical. Very nicely he has named this topic. Non-critical yet critical, managing hyperglycemia in non-critical care setting. Not ICU, but non-critical care inpatient setting. Over to KK. KK, all is yours.
Thank you very much, respected Chairperson, sir, Madam. Okay. Can we start this slide? Okay, thank you. So at the outset, I would like to confess something. In my MBBS studies, about 8 units. So 10 units is before lunch, sugar is 301, so I will add 8 units supplemental and make it 18. Now the blood sugar has come down. Next day when I come to the ward round, I will change my prescription. So look at the top, before breakfast is 12. In the next prescription, before breakfast becomes 18 now. So I increase the breakfast dose so that the pre-lunch blood sugar comes down, and now things seem to plateau. So this is a very interesting study of several lakhs, not thousands, several lakhs CBGs done, capillary glucose done in inpatients in UK setting. They correlate everything together, and you can see on the left is blood sugar levels less than 70, and on the right is blood sugar levels less than 54. Below is the time, which I don't think can read properly, but what I can tell you is the maximum hypoglycemia occurs between midnight and 4 a.m. during inpatient setting. Maximum. That's the worst time to be, because nurses think that the patient is sleeping. Patient is actually not sleeping. He's comatose probably with the hypoglycemia. So that's why if a patient has got hypoglycemia at any time during the day, I tell them check at 3 a.m. And many times I found out the patient is becoming hypoglycemic at 3 a.m. So even if, and that's one of the reasons I don't use the basal at night, I use basal in the morning, because I can adjust the dose straight away. I can do a little bit higher fasting level. I can manage the slightly higher fasting level during the daytime. I do not want nocturnal hypoglycemia. So now with the basal insulin, you have got now emerging data with Degludec. So this is one study, observational data, which shows using Degludec as the basal insulin, a nice reduction of the fasting glucose on your left, and on the right, the average plasma glucose coming down nicely. There is data comparing Degludec with Largine, which shows that even at day 1, you get significant reduction of blood sugar. Mind you, Degludec is a long-acting molecule, so you don't expect the full effect to be there about 3 days. But 70% of the effect occurs at day 1, so you will still get a substantial amount of reduction, and you can adjust the dosage on a daily basis. Now I'll talk to you about variability and how important it is. So in this study by Simeoni, so on admission, you look at the blood sugar level there and look at the variation. So up, outside range, and down below it. Now added every day as the basal insulin, now that seems to come down nicely. So I told you, the variability, more the variability, more the mortality. So that tends to come down nicely, and here you can see, once it is established, the variability comes down nicely. With the Degludec as well, the sugar levels, which is shown here in patients who are naive and patients who are previously on other basal insulins, when you change it, the majority of the time the blood sugars are in normal range. But this is achieved, and importantly, this is achieved without increasing hypoglycemia, in fact with lowering of hypoglycemia. In this particular study, there was 0.07% per patient per day incidence of hypoglycemia. So then another Spanish study with the IGOS, again this is an observational study, so this is not an accurate RCP study, where doctors, if they are not happy with the basal insulin the patients were given inpatient, they changed to Degludec, and with that the blood sugar tended to improve as compared to Glargine 100. Pre-lunch the Glargine seemed to be better, but fasting, pre-dinner, at bedtime, the Degludec seemed to be better with improvement in hypoglycemia as well. So you can see that the switch to Degludec seemed to reduce the patients without hypoglycemia. The bold dark blue one is without hypoglycemia. 85% of patients did not have hypoglycemia once they were switched to Degludec. Now, I'm more excited actually about the basal, about the bonus insulin. And the newer bonus insulins are actually very, very much favorable for inpatient care. This is one study I did in the United Kingdom. So there, I divided the patients into 2 groups. One group of patients, they were already taking the insulin at home. So I told them, you take your insulin as you were, I'm giving you, this is your insulin protocol, you take that. You write down when you are taking the insulin, when you are having your meal. Another group, I said, you will not be injecting your insulin, the nursing staff will be injecting the insulin. Then I wanted to find out whether the patients gave the insulin on time or whether the hospital staff was giving it on time. And this is in the second largest hospital in UK. And to my surprise, the insulin timing, when the patients took it, 78% took it accurately. And when the nursing staff delivered the insulin, only 20% gave it on time. If this happens in there, I'm sure here as well, the numbers will be far more. So the advantage, therefore, of the newer analog insulin is the timing. Also, we are carbohydrate eaters, so we have got more postprandial surge. Therefore, the newer insulin, the faster insulin, therefore, has a really good role in our inpatient management. So here, this is the normal pancreas secreting insulin. We have got the regular insulin that we use, and this is the rapid-acting insulin, the aspart, the Lispro, the glulisine, and we have got the fast-acting aspart, which is even quicker. So here we have got comparison of the faster-acting aspart given before meal, during meal, and up to 20 minutes after meal. Many of the patients may not be able to eat on time. They may have nausea, so we don't know whether they're going to eat or not. For those patients, we can give during the meal or just after meal. That's the biggest advantage I find if you use bolus, the modern analog insulins as the bolus. So the flexibility of aspart, you can give between 20 minutes before to 20 minutes after meal. So that's why I feel it's relevant. So the last few slides, transition from ITU to ward. So patients are on IV insulin, how to change it to subcut insulin. So here you calculate the 24-hour requirements of IV insulin. But suppose somebody is on 12 hours only IV insulin, then you want to change it. So you double the amount. So total insulin required in 24 hours IV, 80% of that will be your dose subcut. Of that 80%, 40% will be basal and 60% will be bolus. Now, this shows you, so suppose somebody in 24 hours is requiring 38 units, so you will give 16 units as, so suppose they are giving 48 units in 24 hours, 80% of that is 38, of 38 you give 16 as basal and the rest as bolus. Now, one common question asked by surgeons, my surgical friends keep asking me this. अच्छा ये बताओ एक यूनिट इंसुलिन में कितना शुगर कम होता है? Then I also tell them, you tell me today Virendra Seva is going to that, how many rounds is he going to school? How can I tell? It depends on the pitch, depends on the bowler, depending on the mode of Virendra Seva, we don't know. So for insulin, you cannot say one unit will drop it by this much. It varies from patient to patient. Extrapolating data from type 1 diabetes CGMS studies, you can say the total requirement, so suppose for this patient 38 units was required in 24 hours, 1700 divided by 38 is 40, so roughly 1 unit will reduce it by 40. This is from type 1, very difficult to extrapolate that to type 2. So I will steer away from this, if 1 unit may kitna kam hoga, you cannot say that. So, nephroblastic feed, parenteral feed. TPM I find very challenging. The blood sugars tend to really run high. We have a lot of difficulties in controlling it. Many times I give IV insulin for 24 hours, then calculate the total dose. But for RT feed, it is not that laborious. So this is an example for RT feed. The blood sugar at 6 a.m. with hyperglycemic range, 12 on 320, bolus insulin given, came down, again became hypoglycemic. Why? Because many of the hospitals, the RT feed they provide is from 6 a.m. to 12 midnight. There is no feed given from 12 midnight to 6 a.m. So if you give a high dose bolus insulin in the evening, patient is bound to get hypoglycemia early morning. So therefore, for rice tube feed, the best is you give a bolus insulin dose, a basal insulin dose. You give the basal insulin, you check the blood sugars every 4 to 6 hours. If it is high, suppose you give 20 units of basal insulin, so you check it every 4 hours. One reading comes up at 250. You give 6 units of bolus insulin at that point. Next day, you instead of 20, you add that 6, so 26 units basal insulin. So every 4 to 6 hours. That's the way to proceed. So I think I will summarize, because for want of time we're running late. So inpatients is an important but often neglected area. This is the area where maximum litigations occur. If any person dies of hypoglycemia, I can guarantee that you will be called to court. If the hypoglycemia after 2 days ago when the patient died, after 2 days, no, that hypoglycemia killed my patient. Basal bolus versus sliding scale, so we have to steer away from the sliding scale. I've told you why you should steer away from the sliding scale. I've told you how to calculate the total dose of insulin, how to divide it into basal and bolus. So choosing the regime with the least hypoglycemic effect and least variability, that's be the motto. So with that, I am. Thank you very much.
Thank you, Kalinda. Dear friends, the organizers have given time at the end, full 15 minutes plus, and we'll definitely have it just because of his time for the discussion. Please keep your questions ready. You can pass on so that we'll save time, and also you can ask from the floor also. But total time for discussion will be 15, 16, 17 minutes to the program after that. So